Good evening, all. It's our case meet number 21. Today's our speaker is Dr.SHARDDHA Madam. Topic name is Pathophysiology and Anesthesia Implications of Geriatric Age Group. Madam is Associate Professor at Krishna Institute of Medical Sciences, one of the beautiful places in Maharashtra, from Karat, and also its Dynamic Secretary of ISA Karat City Branch. Welcome, madam. And this one is our platinum jubilee celebration and silver jubilee celebration year. So we are doing this every week case meets. So welcome all of you on this evening. Madam, please you can start.
Thank you very much, Dr. Chandolkar sir, for inviting me on this forum. I have been seeing all your activities and you have been very dynamic, taking weekly academic activities. I really appreciate your dedication for this. And I'm more than glad to be here on this forum. And greetings from Krishna Hospital and Karat City. Should we start?
Thank you, madam. Thank you, madam. Today's our panelist, Dr. Prashant Kashika sir. He is ISA City Branch Secretary. He will join shortly, ma'am.
Yeah.
So you can please continue. Thank you. Thanks.
Should we start?
Please.
Is the screen visible now?
Yes, madam. It's visible.
Okay. Visible and changing?
Yes. No, not changing, but it's visible.
Oh, the same problem again. Wait.
No. You didn't start the slideshow. You just start the slideshow.
I have started. Just a second.
Madam, click on the resume slideshow. There is option which is showing resume slideshow.
I did that. I'll just do it again. Wait. I'm getting the same problem again. Just a second. Yeah. It is stuck, right? Resume slideshow. No, it's still stuck.
You make custom slideshow or whatever.
Okay.
Or what did you did something?
That worked last time. Does it move?
No.
It's not moving. But,
No.
no, madam. Now it's moving, madam.
Is
But
it so? Wait.
yes, it's moving.
Wait a second.
But madam would suggest you just close once all the windows, then
Yeah.
again just reopen it.
Yeah, that would be better. We'll try one more time. The moment I start the slideshow, I don't know what is going on.
Yeah, it will take 10 or 20-second delay maybe.
It's the moment I click the slideshow button, it goes away. It pauses.
Maybe this happens when the overloaded data is there in your PC or laptop. So
Okay.
work with slow. Yes.
Should I wait for us?
Yes. You click it on that resume slideshow and wait. It will come.
Sorry for the technical snag.
You close this, madam. First, this slideshow.
See, if I end the show, it starts
Yes.
screening.
Yes.
Okay,
Yes, we can start from this.
wait, I'll try to do something here itself. Sorry for that snag. No. No.
Click on resume slideshow, madam, and you start. Nothing, whatever we will see. Continue with this one.
Okay. Should we start with this? What to do?
Yes, ma'am. Nothing. No.
I'm so sorry. Let us see
Yes.
something coming up. Last chance. No, it pauses. I don't know. The moment I start sharing, make it to the slideshow mode, it stops. Okay. Never mind.
Madam, you can continue with this.
Okay.
It will be visible very much.
Yeah, yeah. Okay. I'll try to zoom it a bit if you wish. Visible enough? Screen is visible enough?
Yes, yes, visible.
Yes, ma'am. Yes. Yes.
Okay, I'm so sorry for the technical snag. Good evening, everyone. I am Dr. Shraddha from ISA Karat City branch, and I guess I'll have to, take the slideshow this way around. So today I'll be discussing with you the pathophysiology and the anesthetic implications of the geriatric age group. So coming to some basics, as per the 2011 census, 8.6% of the population is in the geriatric age group. That means above 60 years of age, and it was expected to rise by 10% by now. The average life expectancy in India being 68 years, and as per the WHO's prediction, the number of elderly people will be doubling by 2050. So we are going to definitely have a lot of older age group patients coming on the table for us to anesthetize them. So dealing with this delicate age group becomes important for us. So the outline of this lecture will be somehow, we'll go through the physiological changes of the geriatric age group. We will see what their anesthetic implications are. We will go through the pharmacological principles in the elderly, and we'll see what are the goals while we conduct anesthesia for them, the perioperative goals and the postoperative pen management in short. So as you grow older, what exactly changes? Don't mind, Dr. Chandalkar, I'll just quickly try some slideshow. It is stopping. Never mind. Get back. Never mind. So this is fine with you all. I'll continue. So what exactly changes as we grow older? So each and every system faces some changes. So let's come to a favorite cardiovascular system first. So there's something called as endogenous beta blockade, and the heart responds less to the beta adrenergic stimulation. And then there is stiffening of the myocardium, and there is reduced arterial compliance. Now this reduced arterial compliance will in turn lead to your elevated systolic pressures, your increased afterload, and in turn left ventricular hypertrophy. Now, the left ventricle hypertrophies at the cost of the left ventricular cavity. And of course, there are conducting system changes in the SN node. There is decreased baroreceptor control, which makes it more prone for decreased heart rates and arrhythmias. And there's diminished ischemic preconditioning. And although the systolic function remains preserved in most of the hearts which are otherwise healthy, the diastolic dysfunction is commonly seen in the elderly population. So because of all these changes, what we face, like I told you, is we usually face more higher systolic pressures and increased afterloads in them. The conduction system changes and the baroreceptor control makes them more prone for the intraoperative arrhythmias, more prone for intraoperative hypotension. There is decreased resting heart rate. So in fact, after the age of 50 years, the resting heart rate, decreases by a certain amount. And due to the decreased cavity of the left ventricle, we do face the increased left ventricular end diastolic pressures. So this is how the young heart looks, whereas this is how the older heart looks. You can see the hypertrophied myocardial cells, and the thickened left ventricular wall, and the reduced LV cavity. And you can see how the arterial stiffening is happening, and there's a lot of fibrotic tissue there that is leading to the reduced compliance of the arteries and therefore the elevated pressures. Coming to yet another important system, we can't stop talking about the respiratory system. Now, the respiratory system faces increased chest wall rigidity, and the most common problem that we face is the closing capacity exceeds the functional residual capacity, leading to the closure of smaller airways even at tidal breathing volumes. So all this is leading to increased work of breathing. There is blunted response to hypercapnia and hypoxia, and there is impaired laryngeal and cuff reflexes, making these people more prone for aspiration. And also there is decreased PaO2. So all in all, combined with other changes like COPD, pre-existing COPD and all, makes this PO2 reduce even further. So these elderly patients are more prone to face VQ mismatch because their residual volumes have increased, their vital capacities have decreased. So there is more of ER, what do you say, the RV and the ERV is increased, whereas the vital capacity has decreased. There is increased anatomical and physiological dead space. And because of all this, we need to pre-oxygenate these patients well before we induce any kind of anesthesia on them, so that we get adequate time during intubation and stuff like that. And like I told you, because of the impaired ventilatory reflexes, impaired laryngeal reflexes, sorry, they are more prone for aspiration pneumonia, and therefore adequate care has to be taken. They have to be given antiemetics and all the H2 blockers and all the prophylaxis before especially inducing them for general anesthesia. So these are the tidal volumes. So you can see there is more residual capacity, and whereas the vital capacity, see here, the functional residual capacity and the vital capacity goes down in an aged lung, whereas the residual volume has been increasing. Coming to CNS, there is some chemical loads are happening here with decreased GABAergic, cholinergic, and dopaminergic neuron. The overall cerebral blood flow comes down, the cerebral mass comes down, and the cognitive and psychomotor dysfunction is very, very common in the elderly age group. So therefore, because of this changes in the GABAergic and cholinergic and dopaminergic neuron, elderly adults have an increased sensitivity to anesthetics, and also they are more prone to face postoperative cognitive dysfunction and postoperative delirium after their anesthetic procedures. Coming to the renal system, the renal blood flow and the renal mass both decrease. There is a lot of fibrotic tissue that gets replaced with the renal mass. There is reduced GFR, approximately 1 ml per minute per year is what is how the GFR reduces after 40 years of age. And there's impaired tubular function, there is impaired concentrating and diluting capacity, and all this leading to decreased drug excretion and impaired potassium excretion, leading and making these patients more prone for hypo and hyperkalemia, more prone for delayed recovery from anesthesia, because most of the drugs are anesthetic drugs, especially the muscle relaxants, are excreted through the kidneys, and the impaired excretion and impaired metabolism leads to prolonged effects of these drugs. And as they say, the elderly people are fluid intolerant, as in they cannot tolerate overload and they cannot tolerate dehydration as well. So the fluid balance has to be meticulous, and there is a predisposition of this elderly adults to develop acute renal failure in the post-operative period. The metabolic, endocrine, and musculoskeletal changes, there is decreased muscle mass, whereas there is increase in the fat mass. This happens more commonly in the elderly women more than men. Impaired shivering, impaired thermoregulation, making these patients more prone for intraoperative hypothermia. Impaired glucose tolerance and deficiency of hormones like thyroxine, growth hormone, renin, or aldosterone. These patients most of the times have arthritis, and hence we face problems in positioning as well as neck extension as well as laryngoscopy, where all these joints come into place. There could be arthritis of the TM joint, the spine, and the smaller joints. So everything from positioning to laryngoscopy can get difficult. Of course, fragile veins, we all have experienced how they have very, very delicate veins, and venous blowouts are common. After the systemic changes that happen due to the age, all this kind of has a changes the pharmacological implications of the drugs that we routinely use in patients otherwise. So what basically happens is, in the elderly patient, the total muscle mass comes down, so whereas the total fat mass increases, and also there is a decrease in the total body water. So the total body water is decreasing, the fat mass is increasing, and the total muscle mass is also decreasing. So what happens because of this is, because of the decreased total body water, there is a decrease in the central compartment, leading to higher plasma concentrations of the water soluble drugs, especially after rapid IV bolus. So these drugs are bound to have exaggerated or prolonged clinical effects, whereas the increased fat mass leading to increased volume of distribution prolongs the effects of the lipophilic drugs. So impaired biotransformation and clearance of drugs due to decreased hepatic and mass, as well as the impaired and reduced GFR, is also playing a role, leading to prolonged action of drugs or increased sensitivity of the drugs which are given to the patient. And decreased GABAergic neurons also leads to increased sensitivity to anesthetics, especially the induction agents that we used. So all in all, we are more likely to land up in prolonged drug actions, and or you can say unpredictable course of actions with the doses that we normally give for all adults. So we have to be very, very careful. Maybe we can titrate the dose to effect, and use some neuromuscular monitoring, especially where the muscle relaxants are involved, and go slow on induction agents is what we can do for these patients. Coming to volatile anesthetics, there is a decrease in the minimum alveolar concentration, around 5 to 6% decrease in NAIK is seen per decade after 50 years of age. There is also altered uptake and distribution of volatile anesthetics because of the VQ mismatch and the reduced cerebral blood flow, leading to the increased sensitivity of patients to volatile anesthetics. Now, delayed recovery is also possible due to the increased volume of distribution and decreased hepatic function and impaired pulmonary gas exchange as well. So we have to be titrating the volatile anesthetics as we administer them to these patients. For the non-volatile anesthetic parts, around 40 to 50% reduction of induction dose of induction agent is advisable. There is increased brain sensitivity to opioids and benzodiazepines due to the changes in the neurotransmitters involved. As far as the neuromuscular blockers are concerned, the response to scoline is more or less unaltered. In elderly males more than females, the plasma cholinesterase levels are said to be changed. So there could be some altered response to scoline, but more or less the effect to scoline remains unaltered. Use lower loading doses and take into consideration the renal and liver function of these patients when you use neuromuscular blockers. And pharmacological profile of drugs like atropurium and cisatropurium, which are not mainly dependent on the liver or kidney for their excretion, is more or less less affected, and these drugs would be preferred or should be preferred for as your agents for neuromuscular blocking in the elderly patients. Also, reduced doses of local anesthetics should be used because the minimum concentration, the C minimum of the local anesthetics also comes down. So reduced doses of local anesthetics are also advised to avoid systemic toxicity of local anesthetics in these patients. Coming to the anesthesia implications of all this. So the goals of any preoperative evaluation is to identify and optimize the pre-existing risk factors, because these age group of patients are invariably bound to have some comorbidities in the form of hypertension or diabetes or arthritis or COPD or any other things like that, and preserve the nutrition, cognition, and the functional reserve of these patients. Coming to the pre-anesthesia evaluation. So when these patients walk to you for a pre-anesthetic visit, we got to have a detailed history of the pre-existing comorbidities of these patients, on how many years they have been carrying these comorbidities with them, the associated complications they are facing, what drugs they are taking, and also the history of the functional capacity of the patient, as in how much limitations of the normal functional ability do these patients face, whether they are able to do their routines activity independently and in a proper manner, or there is some functional limitations to this patient, because it makes a hell lot of difference for anesthetizing an old patient who is walking in into your OPD, he's living a normal healthy life and doing all his activities on his own, as compared to an old patient who is having comorbidities and is bedridden for some reason, and getting breathless for walking few steps and is not able to do his household activities with ease. So there's a lot of difference in the spectrum of anesthetizing these two patients, even if they're of the same age. So detailed history of functional capacity is of paramount importance. The drug history, as I told you, the continuation of the essential drugs and discontinuation of others, like which are not suitable for the anesthetic procedures, and the clear orders of that sort to be explained to him. The thorough airway evaluation of these patients is important. We'll have to look into the cognitive function of this patient in the pre-op period, which will predict you the course of the post-operative cognitive dysfunction that he or she might face. The routine laboratory testing and good cardiorespiratory evaluation will give you a pretty good idea of how the picture will be for this patient in the perioperative period. Coming to the airway, I'm not sure with the slideshow, we're not clear how much you will be able to see this, but the anatomical variation in the young and elderly basically depends that these patients are essentially edentulous, or the dentition is, with missing tooth or dentures. So the dentition is not clear. They are either damaged or half absent, or the patient is edentulous. Then the buccal pad of fat is lost, making the cheeks hollow, and all this kind of makes the mask holding difficult as compared to the younger counterparts. Also, arthritis of the TM joint, or any issues with the C spine makes it difficult for us during laryngoscopy as well. So the tissues of the oropharyngeal airway are essentially fragile. These patients are liable to, the airway is liable to be traumatized, to bleed very, very easily. And sometimes the mouth opening could be restricted. And all this, the impaired neck movement, the restricted mouth opening, the lost buccal pad of fat, and the missing teeth or loose teeth or edentulous jaw makes it slightly difficult intubation or mask holding than the adult young counterparts, and that has to be taken into consideration. So therefore, a thorough airway evaluation becomes mandatory. The Lemon criteria of look, evaluate, the Malampatti, any obstructive features or things, and the neck movement have to be assessed in the preoperative period, so that you can keep your airway plan ready. A difficult airway card should always be around when you are intubating or anesthetizing a geriatric patient. So like I told you, these are the technical difficulties in geriatric patient, because there's lost buccal fat, the patients are edentulous, there is restricted neck movement, there are other issues like GERD, and if the need be of a awake intubation, geriatric patients mainly, most of them have this mild cognitive impairment, and it becomes difficult to achieve cooperation of these patients if they are planned for an awake intubation. There's something called as frailty assessment. So decrease in the reserve is often labeled as frailty. So adult elderly patients are frail, like we say. The decrease in reserve is labeled as frailty. The frailty indices improve the risk prediction for post-operative complication. There are n number of frailty assessment tools and scales that are present. So clinical frailty, few of them are like clinical frailty scale, which is nothing but you assess the activity of the elderly, like I already discussed. Look through into their functional capacity, their daily routine, how much they're able to walk around, move around, do their routine course or work, or they're basically the functional status of the patient. Then there is reported Edmonton frailty scale, which looks into the cognition, nutritional, functional performance, and social support. There is modified frailty index, which looks into the history of coexisting disorders like diabetes, COPD, CCF, myocardial infarction, angina, hypertension, which requires medication, previous history of dementia, CVA, etc. So all in all, this gives you the idea of how much is the decrease in the reserve of the patient, and therefore helps in you in the risk prediction in the post-operative period. Assessment of cognition becomes important in this age group because it helps you predict the course of post-operative recovery and the risk of post-operative dementia and post-operative cognitive dysfunction, which is a major issue in the geriatric age group. Again, a host of tests are available to check the cognitive function: the clock drawing test, the Minicop test, the impairment, memory impairment test, mini mental state examination, and a lot of others. So I have just mentioned a little bit about Minicop test here. So Minicop test is basically two scale. So what they do, they give, we ask the patient to take a 3-word test. So we'll ask the patient to memorize, we'll tell them 3 words, any 3 small basic words, and we will ask them to recall it. So as a distractor, we'll give them a set of 3 words. We'll ask them to repeat it, after which the patient is asked to draw a clock. And a timing is given. Say we'll ask them to draw a clock and mark as 10 past 11, or mark 9:30 or half past 9, and ask them to draw that clock. And after the clock is drawn, we ask them to recall the 3 words that we had told them earlier. So this clock drawing test is basically what they say as the informative distractor, and then the score is taken. So if the patient is not able to recall any word out of the 3, he is known to be demented. If he can recall all the 3 words, then he is not demented. But if he can't recall 1 or 2 words, then that's the place where this clock comes into place and helps you rate him better. So if he can recall 1 or 2 words and the clock that he has drawn is also abnormal, then he's probably demented. But if he can recall 1 or 2 words and the clock drawing is normal, then we label him as non-demented. So this is the Minicop test, most simpler one and most commonly done. So coming to intraoperative management, certain things that we need to be careful is that these patients have very loose skin and they are very liable for pressure sores. And the venous blowouts, as I discussed, are very, very common. So the veins are very fragile and have to be cannulated very precariously. Proper monitoring is required because these patients are already having pre-existing comorbidities. They are excessively sensitive to the routine anesthetic drugs, the opioids, the induction agents, the neuromuscular blockers that we use. Thermoregulation is impaired, so maintaining a warm environment, maintaining the whole body temperature, use of warming blankets, warmed IV fluids becomes very, very important. Goal-directed fluid therapy so that they are neither underperfused nor overperfused. is important, and a difficult airway card, like I discussed, should always be ready in the OT when we are taking up a patient of geriatric age group. Now, when we say intraoperative, so the question comes whether regional is better for this age group or whether GA is better for this age group. So there are multiple studies which have been done, but none of them have come to any strong conclusion that any one kind of anesthesia is standing better over any other kind of anesthesia. So GA as well as regional have their own pros and cons, and there is no contraindication for any of these modes of anesthesia for the elderly age group. So as far as we know what we have to anticipate, regional and general anesthesia are both equally fine for a patient of geriatric age group. Yes, there are certain advantages of both over each other. Now, this is one study that has been done in comparison of general and regional anesthesia in terms of mortality and complications in elderly patients with hip fracture. So they were undergoing hip surgery and they have studied some 96,000 odd patients, of which 25,000 received GA, while 70,000 received regional anesthesia. And they said that regional anesthesia was associated with better outcomes than GA in terms of mortality, delirium, ICU admission, and ventilator care in patients who underwent hip surgery. Whereas this other study, which was a basically systematic review of which anesthesia is better, in hip fracture for post-operative delirium, and they found out that no one type of anesthesia influences the post-operative cognitive function or the mortality. And the authors also said that the evidence base is lacking, and we have to have more adequately powered and methodological studies, which will maybe come out with one answer. But for now, there is no one kind of anesthesia which is better than the other kind of anesthesia. We just have to be careful and vigilant. If you're talking about regional anesthesia, the difficulties that we face here is firstly the difficulty in positioning. It is, most of them are scoliotic, or they have pains in some joints here and there, and it is very difficult to position them. Maybe sitting, maybe lateral. It is difficult to position them for your regional blocks. Even for giving a block, for that matter, neck extensions, that becomes painful to them. So there is difficulty in central neuraxial blockade. The spaces are narrow, they are calcified, they are crowded, there is kyphoscoliosis. So most of the time a paramedian approach helps, or if if you have a USG machine, you are lucky. So the USG guided approach also helps. There are a lot of pre-existing neuropathies that you have to take into consideration while giving regional blocks or central neuraxial blockade, and maybe you'll have to mention them in your pre-operative sheets, whatever neuropathies the patient is facing. And also reduction in dose of local anesthetics is one thing that we have to be careful about, so that we don't land up into local anesthesia toxicities. Even for that matter, epidural anesthesia, what it is observed that the spread of the drug in the epidural space is more cephalad in these geriatric age group for the same amount of drug that we give for the younger counterparts. Coming to general anesthesia, it has its own set of problems. You're bound to have sudden hemodynamic changes, as we discussed. They have a fragile central venous system leading to sudden hypotension, or that could be sudden hypertension with the surgical stimulus, and lot of pharmacodynamic and pharmacokinetic changes going on, and the sensitivity of these patients to various drugs is erratic, and the metabolism or the renal and GI, the renal function and the liver function is being impaired. The metabolism of the drugs, the excretion of the drugs, and therefore the awakening time and the recovery profile of these patients might change. So we have to be very cautious, and the best strategy to follow is start low and go slow. So we start with lower drugs and we gradually increase and titrate them to effects. That's the best policy we can follow for a safe anesthesia outcome for patients undergoing GA. There has to be adequate pre-oxygenation before the intubation or before the induction of the patient, so that we get good time for handling the airway in case it is difficult, and these patients are also liable to desaturate faster. Lung protective ventilation with lower tidal volumes and higher rates is advisable. Prevention of hypothermia and fluid maintenance of fluid balance is also important, especially under general anesthesia. Coming to post-operative part, the primary concerns are the post-operative pain, the post-operative cognitive impairment, the nutrition, and the post-operative pulmonary complications, UTI, pressure sores, venous thromboembolism. Coming to cognitive impairment, some amount of mild cognitive impairment is common in the elderly age group. The common signs which we can recognize is forgetfulness, lack of attention, impaired judgment, or problem with reasoning, planning. They cannot remember certain things very easily. They cannot remember the recent things very easily. So short-term memory changes are the most common. So the post-operative cognitive dysfunction is mainly of the early onset, as in early onset after the surgery and the anesthetic exposure. So there's some certain risk factor which predispose them to POCD. The patient factors being advanced age, and there are pre-existing cerebral, cardiac, or vascular disease. There could be mild pre-existing cognitive impairment already. Low educational level is one important factor for POCD, and history of alcohol abuse. Surgical factors include extensive surgical procedures or intra or post-operative complications, blood loss, intraoperative ischemic events, and all these things. Anesthesia related will be a long-acting anesthetic or prolonged surgeries, marked disturbance of homeostasis, organ ischemia due to hypoxia or hypoperfusion, and the intra and post-operative anesthesiological complications. All these predispose the patient to post-operative cognitive dysfunction. Whereas post-operative delirium is mainly of late onset. It can come after few days or even weeks of the anesthetic exposure. Again, increasing age, reduced cognitive reserve, pre-existing dementia, multiple comorbidities, pre-existing in visual and hearing impairment, alcohol or drug withdrawal, polypharmacy, sugar and electrolyte dysfunctions, and pre-existing infections are the predisposing factors which might push the patient into post-operative dementia. A quick table which will summarize the basic difference between the POCD and the POD, like I discussed. So POCD is subtle onset, whereas post-operative delirium comes suddenly after an interval. Whereas POCD is a gradual deterioration post-surgery, post-operative delirium will come after few days or maybe weeks. And POCD mainly has discrete memory problems. There will be some personality changes. He will not be able to remember things. He will not be able to perform his daily tasks. He'll forget what he has kept. And in severe cases, it will it might go to psychomotor problems. But in the post-operative delirium, the main symptoms being this disturbed consciousness, there is altered consciousness, there is hypo or hyperactive forms of delirium. Again, pathophysiology, as we discussed, in the POCD, it is more of the effect of anesthetics or the effect of chronic diseases or advanced stage of the patient, low educational status of the patient, and prior cognitive impairment are the primary factors leading to POCD. Whereas in post-operative delirium, there's more of neurotransmitter disturbances, pre-existing dementia, dyselectrolytemias, or even a genetic component is said to exist. Treatment essentially remains identifying the cause of it and supportive treatment. In post-operative delirium, in extreme cases or refractory cases, haloperidol may be used. Coming to the pain management in the elderly. The basic challenges again that we face in the pain management area is communication difficulty. They might not be able to communicate with you the intensity of the pain, leading to improper evaluation, poor validation of the tools that we usually use, the pain scales and the visual pain analog scales. they might not be able to use it correctly because of the cognitive impairment. There is poor compliance. They are resistant, they are stubborn, they don't take their drugs properly, and the pain threshold is low. And again, the pharmacodynamic effect of the various drugs, and there is increased sensitivity to opioids. You give some opioids and there might be some respiratory depression happening, and all in all, things might get complicated. The side effect profile worsens because of the changes, physiological changes, and the impaired or poor reserves. And all these become the challenges in adequately and effectively managing the pain of these elderly patients. But if you don't manage this pain adequately, it only leads to worsening of the delirium or agitation or the cognitive impairment that the patient might go through after your anesthetic procedures. Verbal scoring system, like I told you, may not be reliable, but if you see a patient, post-op patient whose delirium is worsening or getting agitated or doing facial grimaces or not able to sit properly or having altered postures, all these points towards inadequate pain relief. So basically, we all follow the WHO analgesic ladder kind of. The step one will be your basic drugs like paracetamol or NSAIDs. Again, NSAIDs again depends upon the renal parameters of the patient. If it doesn't take care of the pain, then we can switch on to a little weaker opioids for mild to moderate pain, like tramadol or codeine. And if that doesn't help, only then we come to stronger opioids like fentanyl or morphine and more such. Adjuvant treatment in the form of even counseling or psychotherapy might help in these patients. We have to be very, very careful while using stronger opioids and have to be done under monitored conditions. Opioids and should be best given with stool softeners and other supportive therapy so that the side effect profile comes down and patient is comfortable on them. Regional blocks do help a lot in adequate pain management of the elderly patients, but they again have their own problems in the form of, like I told you, positioning and anatomical issues and the patient cooperation and stuff like that. And ultrasound guided regional blocks wherever possible are the best form of pain therapy relief that we can probably give to such patients. Also, non-pharmacological methods like TENS and acupuncture and psychotherapy have been tried with good results in the geriatric population, along with the pharmacological methods. Non-pharmacological methods can be used as supportive or adjuvant therapy for better results. So the take-home message that we need to understand aging is not a disease. It is only a gradual change that the body is going through over the years. So we have to maintain the nutrition, cognition, and the functional reserve of these patients at all the times. These patients are more likely to have comorbidities in them. So thorough preoperative examination to determine any underlying undiagnosed disease is must. We have to maintain the homeostasis throughout the perioperative period. Go slow and go low is the best mantra for any of the drugs that we are using in these patients. And we need to treat the elderly with care, dignity, and respect. So basically, older patients are nothing but, again, small children. All they need is some tender, loving care. Thank you very much. I am very sorry the slideshow mode was not playing today. Thank you so much.
Thank you, madam. Very nice presentation. And we cover almost all aspects in geriatric patients.
Thank you, sir.
Yes, ma'am.
Do we have any question?
Yes, I'm checking. From audience, any question? Yeah, from Rajiv. It's very informative presentation. Question answer box.
Sir, this शेवटी दिसल्या का slides थोड्या तरी, because it will not give the effect of a slideshow, but I had no option.
Yes.
something was not working today.
Yeah, somehow it's not working. That
आधी check केलं तेव्हा झालं होतं ते and suddenly
no,
it's not working.
Any question from audience? I think you covered almost all aspects of geriatric patients. So I don't think anybody having any questions on that, because you covered almost from regional. You covered everything, and our main aspect is CVS and RA. That also you covered, and also Airway is also covered. So I don't think anything different aspects from cognitive functioning testing are in our aspects from private practice forum point of view. We that much we don't bother on that aspects. Yes. So,
but even general questions like, you know, the memory based can give you a slight idea of how these patients might be. You don't have to actually conduct the Minicop test, but you know,
yes.
do they remember something in the recent past? Do they have this habit of forgetfulness, or do they find it difficult to plan or execute something? थोड़ा सा बोलण्यात ना also we can just extract kind of ते थोडा आयडिया येऊ शकते even in a private practice scenario.
Mainly
Or their family members, they tell you this kind of a history. Like that.
These patients are easily identified in arthro cases. Old fractures, old. They come and they told us.
Even while they are brought to the recovery or they are on the table, if you try to ask them history, most of the times they'll show you this kind of impaired response.
One aspect you, I think you missed that hearing problems.
Hearing problem. I had mentioned it in some slides.
A lot, I think. Maybe I missed.
And
a lot of even they don't ask. Maybe they are spinal is so subjective. You have to ask them.
And they don't understand what you do, and then you lose the cooperation because they cannot hear you.
Yes.
You can't explain.
Even they don't cooperate also. Most of them.
They don't understand. They don't cooperate. Please log out and log in. That might help. Yes, I should have done that. Nice. Would have helped.
Yes.
Somebody suggested.
I also see just now. I think, madam, no questions from audience. Whatever topic you covered, almost everything. I also was about to ask some questions, but next slides you cover that topic, and that was cleared by
either everything is understood or nothing is understood.
Yes.
I assume everything is
one question. One question came from Raju. How do identify age-related cognitive functions from early Alzheimer's pre-operatively before giving anesthesia fitness? It's important.
So identify cognitive functions from early Alzheimer's pre-operatively. So it is, even the Minicop test would help in that case. So I have not put the pictures, but if you see, they draw those clocks very weirdly. And this is one. There are a lot of the MMSE mini mental status test and all are available. If you go on Google, the forms are available. I've not put all the forms here because it becomes unnecessarily long. Minicop test is also
a lot of forms. Yes.
So there are some questionnaires which are available. So if you put that mini mental state evaluation, you get a questionnaire. You just have to, ask them this question or fill it, and you get the answer. It is very and again, like I told you, history from the patient as well as from the relative will invariably tell you a lot of things than going for any fancy test. That is what I believe. You ask them simple lifestyle questions. You ask their relatives a few questions, and they'll tell you, do they have cognitive impairment? Do they have these memory-based problems? It certainly points out towards this impairment, and you probably know that some cognitive dysfunction is waiting for you after the surgical or the anesthetic procedure. Because Alzheimer's also, I think there are some specific tests available. Anything else? Please come up.
Any other question from audience? I think same thing.
Importance of 2D echo in this age group. So, if you have some pre-existing comorbidities like hypertension or any coronary artery disease, or the patient is having some functional limitants in the form of breathlessness and walking a few stairs or walking slightly uphill. So if your clinical history correlates and he has a history of hypertension or say coronary artery disease or history of angina or breathlessness or something like that, I think we can go in for a 2D echo for this thing, because like I said, diastolic dysfunction becomes a little common part in this age group, although systolic function is not impaired. So if the patient is clinically stable without any coexisting, even diabetes for that matter, but if the patient does not have any existing comorbidities, see ECG I suggest for each and every patient. आजकल तो 30-35 में भी हो जाता है सबको cardiac events, but ECG, yes, it is a must for each and every patient above 50 or say let's say 40 that you anesthetize. But echo will depend on how your ECG has turned out to be and clinically correlating with his history and his functional status. So if there is some lacuna in any of these three, I think we should go for a 2D echo for sure. Again, also it depends on what kind of a surgical procedure he's undergoing. So if he's going for some short GA procedure without any history or previous cardiac history with a good functional status, probably with a ECG which is normal or near normal, you're good to go without a 2D echo. But if he's undergoing a major procedure, going to take a prolonged time of anesthesia, or is going to be subjected to a lot of fluid or electrolyte imbalances or GA for prolonged time, echo should always be safer. It will give you an idea of what you have to face in terms of serious. So depends on the patient as well as the surgical procedure he is to undergo.
So mostly in old age groups, the surgeries are related to ortho or general surgeries are there.
It's always safe to get
major surgeries are not happening in these age groups. Yeah,
mostly ortho.
Ortho, because of hampering mobility, relatives also a bit scared that I have to do everything of that age group.
Ortho or maybe Euro. Not URP.
Yeah, yes. Post URP syndrome is happening almost a lot in
this patient.
Yes.
So Euro patients invariably have an impaired kidney also. So they become a little more complicated to handle.
One more question: how to distinguish the question? Can you read?
ICU psychosis and post anesthesia reaction. So
Yes, psychosis and post anesthesia reaction.
Actually, there is some overlap here, I feel, because it depends. You ask, ICU psychosis happens after, see, if the patient is already in the ICU for some reason, then shifted to OT for some laparotomy, taken back to ICU, he becomes, more deliriated, agitated. Maybe the component of ICU psychosis plays a more role, but a patient is wheeled in from a non-ICU setup to the OT and goes back to the ICU. Again, like I said, one of the factors for postoperative delirium is a prolonged ICU stay also. So there is some kind of an overlap here, and more or less the treatment of it will be supportive and identifying the cause rather than, kind of extracting whether this is due to anesthesia or this is due to ICU in the post-operative period. So we will have to find out if the patient has undergone a surgery which has a lot of blood loss that has happened. There were periods of, organ, say like a lot of blood loss acutely happened. And then there was this time when the patient was facing hypotension, we had to push fluids and we had to put him on support. So, some hypoperfusion of the organs could have happened in for some time, and then it has picked up or something like that. Then yes, there are more chances that it is due to the turbulences in the perioperative period that it has happened, more than being purely ICU psychosis. So the disturbance in the homeostasis in the intraoperative period and the preoperative cognitive status of the patient will tell you whether this is more due to the perioperative imbalance that has happened or it is purely due to ICU. Again, I would like to say that it will be a kind of an overlap. So all this imbalance along with the prolonged ICU stay, if it is happening, then it could be a mix of both. But if it is happening in a day or two after anesthesia, so it could be more due to the disturbed homeostasis during the perioperative period.
So related in ICU psychosis, it's due to it's related maybe over fluid.
Yes.
Or over correction or under correction or other thing. But post anesthesia immediate effect mostly due to higher use of opiates than
Opioids.
you said use of weaker opiates. So that may be the reason.
Opioids or even more bouts of hypoperfusion in the surgery. Some sudden blood loss. You try to pick up some for a while. The patient is on supports, then we gradually wean. So chances that these patients land up more into cognitive impairment later.
This question is, I think, we don't use USG guided blocks, but I think you can speak on this. Please tell about nerve block like opportunities.
Practically, I don't practice too much USG guided block in my institute.
Yes, I also.
Yeah, we belong to small town and basic institute.
Yes.
So I'm not the very exact person to discuss on USG guided blocks. Yes, we all do those PNS guided blocks, blind blocks, line bhi karte hum log for that matter. But USG is something comes very slowly in peripheral setups.
Yes, yes.
So maybe sir will have to arrange somebody who is very pro into it.
Yeah.
Does USG
yes, yes. This question will be answered in the next 25th. Session. Yes, next session it will be answered.
I'm not the person who is.
Yes. I also think. I thought at Karad, this is you have.
No, we don't have a USD machine as such. We have asked them long back, but the lot of technical snags that are happening in between.
Yes.
The management has to agree how much ever.
Yes, that's the major part in institutes.
And PCPNDT is the foremost reason.
Yeah. Other thing.
Yes. That's the thing they put forth to us.
Maybe in government setup आहे ना आमच्याकडे तर आमच्या गव्हर्नमेंट मध्ये आहे जीएमसी मध्ये सध्या आहे but they don't use regularly I don't.
But in patients like this, high risk patient, geriatric patient,
yes,
it have to have a USD current.
Yes.
Difficult with the traditional techniques.
I think, madam, all questions are covered, and question from audience. So I think we will conclude this session. Thank you all participants and viewers for this evening case meet. And thanks again, Dr. SHARDDHA madam. She gave us a valuable time.
Thank you so much.
It's a busy schedule and in this weekend. So happy weekend and have a good day.
Have a good day, everyone. Thank you so much.